Hello and welcome everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you for joining us today and our friends at Health Point Midway for hosting today's session, Hypertension Update 2024 with Dr. Charles Schulman. Dr. Schulman is a senior physician emeritus who recently retired from active practice after 53 years, but continues teaching and consulting. In addition, he has been practicing non-invasive cardiology since 1970, and we're just so very, very lucky to have him as a MAVEN Project volunteer. So Dr. Schulman, when you're ready, please.
Thank you, Kristen, and good afternoon, everybody. Welcome to our hypertension webinar. I have no disclosures, nor do anybody else that has had any role in the development of this program. And the MAVEN Project, being accredited to give CME credits, designates this for an hour of Category 1 credit. So we'll start our hypertension talk in the olden days, certainly before any treatments were available, but the health of a very famous politician was involved, Franklin Delano Roosevelt, the President of the United States. And you'll notice here that he had systolic hypertension in his mid-50s. By the time he was 59, his blood pressure was 188/105. 2 years later, it ran between 210 and 260 systolic. It was thought that systolic hypertension was not serious, not significant at that point in time. In 1994, when he was 62 years old, his blood pressure was 240/130, 260/150. He had heart failure, no question, and was treated with digitalis, the only thing that was available at the time. And then in April of 1945, he died suddenly of a cerebral hemorrhage. And according to the doctors that took care of him, this, quote, came out of a clear sky. There was no indication of an imminent danger. Well, we've come a long way since that time in terms of knowing about and treating hypertension. The learning objectives of this activity are to emphasize the use of proper technique when measuring blood pressure, to know blood pressure goals, to implement a strategy for both initial and subsequent non-pharmacologic and pharmacologic management, and to recognize when to look for secondary drivers and causes of hypertension, such as hyperaldosteronism. Hypertension is a pervasive problem. It's estimated that 122 million people in the United States have it. Three out of four of them are not well controlled. There have been considerable numbers of deaths, 124,508 in 2021, with the hypertension listed as a primary cause. And it's considerably costly. The prevalence of hypertension increases with increasing age, so that over the age of 65, 72% of men and 75% of women have hypertension, and those numbers rise to over 80% at the age of 75. Now, this is not new data. This is 20-year-old data relating blood pressure and coronary heart disease death. This was a meta-analysis of 61 studies by the Hypertension Collaboration, involving over 1 million adults And there are a series of curves. This is systolic, this is diastolic. I'll just use this one for the moment. And you notice that there are a series of curves depending on age. So as age goes up, so does blood pressure. And as blood pressure goes up at any age, so does risk. The risk of cardiovascular death doubles for every 20/10 millimeter of mercury increase over 115/75. So there is no such thing. There is no such thing as, quote, benign, end quote, hypertension. There's an association with other cardiovascular disease risks as well as coronary heart disease mortality, stroke, coronary heart disease, and myocardial infarction all increase in frequency from normal blood pressure to elevated blood pressures to hypertension. Now, I'm going to show you just two trials. The SPRINT trial was pivotal. It's a real landmark trial, published in 2015. An NIH study looking at the effect of lower blood pressure target goals. So what they did was they took 9,400 patients, divided them into two groups. One was a standard group with a goal blood pressure of under 140 millimeters of mercury. The other was an intensive treatment group with a goal of 120, under 120. Actually, they achieved a mean of 121. This group achieved a mean of 136. 35% females, 28% over the age of 75, and 30% African Americans. And the primary outcome was a composite of acute myocardial infarction, acute coronary syndromes, stroke, heart failure, or death from cardiovascular disease. And here are the results, both of the trial as a whole and the over age 75 group. And what you see is a 25% relative risk reduction with the intensive group, both for the primary outcome and for all-cause mortality. That's important to note. All-cause mortality was reduced. It was the results were even better in the older age group, 34% reduction. In the older age group, there was more hypotension and there were more injurious falls, but not any of the other adverse events over and above the younger group, age group. Now, this is the second study. It's much more recent, published 3 years ago in the New England Journal. And this was a group of 8,500 Chinese patients between the ages of 60 to 80 who were randomized to standard treatment with a systolic blood pressure goal of 130 to 150 and an intensive treatment group where with a systolic blood pressure of 110 to 130. And basically, the results are the same. That is to say, there was a 26% relative risk reduction in the combined outcome. So your patient comes in, and here are 3 questions to ask when actually, I should change this because it's not while you're measuring the blood pressure, but when your patient comes in to have his blood pressure measured would probably be a better way of saying that. Quote, were you rushing to get here or physically active right before this appointment? Have you been taking your medicine? Have you, what's your diet and physical activity regimen like? And so we turn to the proper ways of measuring blood pressure, and I would ask you what's wrong with this picture. Put your answers in the chat.
Looks like drinking coffee.
Yes, it does, doesn't it? Uh,
Cross legs, legs crossed, talking, coffee, not feet not flat, and has to pee.
yeah, yes, indeed.
Caffeine, just smoked.
Yeah, you're all correct. Cuff looks too low. Well, the problem with the cuff is that it's over his clothing. You take blood pressure on a bare arm, as noted here with the arm at so that the arm is at approximate heart height. But you're all right. Uh, after with an empty bladder, sitting in a chair, back supported, feet on the ground, uncrossed, not drinking, not talking, um, uh, and this is on, as I say, on a bare arm. So this is the proper way of taking blood pressure. Now, in 2017, the American College of Cardiology and the American Heart Association came up with a guideline for the prevention, detection, evaluation, and management of high blood pressure in adults. Previously, that function was held by what was called the Joint National Committee, and their seventh report was 2003. So there's a 12-year hiatus in between. There was a JNC 8, but it never was never official or published. In any event, here are the comparisons. Normal blood pressure was always 120 over 80. In the previous guidelines, between 120 and 140 was considered to be pre-hypertension, and hypertension didn't start till your blood pressure was 140 over 90. The new guidelines have lowered that, at least in part because of the SPRINT study, so that elevated blood pressure is considered to be between 120 and 130 systolic. Stage 1 hypertension starts at 130. That is, the definition of high blood pressure is blood pressure of over 130 over 80. Now consider salt intake and its effect on blood pressure. High dietary sodium intake increases blood pressure. The mean sodium intake in the United States has been estimated to be somewhere between 2,300 and 4,700 milligrams per day. Lowering of salt intake lowers blood pressure and reduces extracellular volume. And these are examples of that in both African American and non-African American patients, both in pre-hypertension and hypertension. The effects in hypertension are greater than in pre-hypertension. So now it's quiz time. Okay. Which one has more sodium? A Hebrew National Beef Frank or 11.5 ounces of V8 juice? Put your answers in the chat. We have one vote for V8. One vote for one vote for equal, another vote for V8. The answer is the V8. The Hebrew National Beef Frank has 480 milligrams of sodium. The V8 has 920 milligrams of sodium. Which has more sodium? Panera Bread Southwest Caesar salad with chicken, or a slice of Domino's pepperoni pizza? Okay, we have two votes for Panera. Any other votes? Another one for Panera. No, another and one for pizza. Okay, and the answer is the Panera Southwest Caesar salad, which has 1,000 milligrams of sodium. The pizza has 830 milligrams of sodium, so it is certainly not low salt. But the salad, it's over a gram. Okay, last one. Which has more sodium? Chipotle burrito or an Olive Garden chicken marsala fettuccine entree? Olive Garden, yeah. Burrito, Olive Garden, fettuccine, right? That would be Olive Garden. Okay, and the answer is the burrito. But you'll notice that the pasta has 2,500 milligrams of sodium. There's considerable amounts of sodium in it. So you're not wrong. But the burrito has even more, has almost 3 grams of sodium. So you can see how eating fast food can certainly contribute to hypertension. The American Heart Association has identified what they call the salty six: bread and rolls, pizza, sandwiches, cold cuts, and cured meats. Soups, especially canned soups, burritos and tacos. 68% of salt ingested comes from processed foods from the grocery store. But another 15% comes from eating in restaurants. Okay, so what are some strategies for sodium reduction at home? Avoid processed food sold in cans, boxes, and bars when possible, and jars when possible. Read food labels and buy low sodium versions of foods. Then stick to fresh foods, cook without salt. Try fresh turkey, chicken, and lean beef instead of cured smoked foods like bacon, sausage, and lunch meats. And try to eat at restaurants less often. The restaurants today are all attuned to people having allergies. So this is not an allergy, but you certainly can ask for low salt items or no added salt on your food. The role aldosterone has a considerable role in the genesis of hypertension. It causes sodium retention and volume expansion. It causes an upregulation of the angiotensin II receptors and a potentiation of the pressor response to angiotensin II. One clue to the presence of hyperaldosteronism is a low normal or low potassium, even despite a potassium-sparing agent or potassium supplements. Now, there are a number of early markers of hypertensive cardiovascular disease, or what's previously been called end organ damage. There is an exaggerated blood pressure response to exercise. So a patient who's undergoing a stress test, whose blood pressure exceeds 190 in women and 210 in men, this is a hypertensive response. And the resting blood pressure may be normal, so that's still an abnormality, and you should be careful to monitor and treat that. Then there's what's called the loss of the nocturnal dip. This is a British expression referring to the fact that in the middle of the night, 4 to 6 a.m., catecholamine levels and blood pressure fall to their lowest levels, whereas they rise in the morning when we get up and around, presuming that this is your normal day. Somebody who works a second shift or a third shift isn't going to, their circadian variation is going to be different than what I'm showing you, but they're still going to have a circadian variation. The problem is for people who don't have a blood pressure drop during sleep. So this is an example of a non-dipper. This would be especially true, for example, in obstructive sleep apnea, because folks who have sleep apnea don't really have a good night's sleep unless they use CPAP. We'll talk about that. Other markers of hypertensive cardiovascular disease include left ventricular hypertrophy on the ECG or on an echo. Reduced diastolic function, so-called DDD, the dread diastolic dysfunction. Calcium in your coronary arteries, which is a finding that makes the diagnosis of coronary artery disease. The only way you can have calcium in your coronary arteries is if you have coronary artery disease. The vascular marker would be increased carotid intermedial thickness in the kidney, albuminuria, or reduced kidney function, and retinal artery changes. Now, these are non-pharmacologic interventions. So we're now turning to treatment. And these are non-pharmacologic interventions for the prevention and treatment of hypertension. Weight loss, for every kilogram of weight reduction, you can achieve 1 millimeter of mercury reduction. The DASH dietary pattern, which is a diet rich in fruits, veggies, and low fat, reducing dietary sodium, increasing dietary potassium, increasing physical activity. So exercise helps. Moderating alcohol consumption. I tell patients if they ingest 3 drinks a day, their blood pressure will be almost impossible to control. And for those who have sleep apnea, it has been shown that if they wear their CPAP mask for more than 4 hours a night, they can reduce their overall blood pressure by 5 millimeters of mercury, but at night they can reduce it by 7 millimeters of mercury. So the CPAP, looking for sleep apnea and treating it with CPAP helps. This has to do with weight loss and blood pressure. So not with specific blood pressure treatment. But here, a study on a follow-up from gastric bypass showed that 5 years later, 5 years post-bypass, with a weight loss of 55 pounds, 47% of those patients were not on any hypertensive medications 5 years later versus only 2.4% of medically treated patients. Tirzepatide, which is a GLP-1 agonist, induces weight loss, and it also induces lower blood pressures, as shown here. Okay, these are the 2008, the latest version of the physical activity guidelines. Move more, sit less, any amount of physical activity has health benefits. So emphasize to patients that everything counts. Everything counts. And I ask people if they exercise. Oh, no, I don't exercise. Oh, well, tell me what your job is. Well, I work at Home Depot, and I walk back and forth all day long, and my step count is somewhere between, 8 and 12,000 steps a day. Well, that's exercise. That counts. The goal is 30 minutes, 5 days a week of moderate physical activity. As a general statement, physical activity helps prevent 8 types of cancer, reduces the risk of dementia, reduces the risk of all-cause mortality, reduces heart disease, stroke, high blood pressure, type 2 diabetes, and depression. And it improves bone health, physical function, and quality of life. For older adults, physical activity also lowers the risk of falls and injuries from falls. It doesn't matter what kind of exercise you do. So aerobic exercise, dynamic high intensity interval training, isometric exercise, or combined, they all work. So emphasize to people that whatever they do helps. In my opinion, a combined aerobic and isometric program is the best one. And so, what I do is I write in the days when we were writing prescriptions, in the days when I had a prescription pad, I would actually write this out on a prescription, right? Exercise. The exercise prescription is the frequency, intensity, and duration. The frequency should be at least 3 times a week, although more is better. Intensity, at least moderately hard or brisk but comfortable. And the duration should be somewhere around 30 to 45 minutes with considerations of a warm-up and a cool-down period. Now, turning to pharmacologic treatment. The 2017 hypertension guideline gave us the following treatment thresholds for adults with high blood pressure. And as with many other treatment guidelines, the most intensive treatment is given to the people who have the highest risk. So if you have a low risk, a 10-year calculated risk according to one of the risk calculators, if your blood pressure is between 120 and 130, emphasize heart healthy lifestyle. If somebody with a low risk has stage 1 hypertension, increase the lifestyle measures and start treatment when blood pressures get to be over 140, over 90. On the other hand, if the patient has a higher risk or has diabetes or has chronic kidney disease, start treatment at 130 over 80, and the treatment target is under 130 over 80. Now, there have been a number of major findings on hypertension since 2017, including the recommendation to use out-of-office blood pressure readings, use home blood pressure monitoring. All adults with difficult to control or resistant hypertension should be screened for primary aldosteronism, and we'll talk about that again in a minute. Young adults with hypertension have an earlier onset of cardiovascular disease events. Even children who have hypertension have a higher risk when they get into, I'm not even sure it's considered middle age, but they, even before the age of 40, they have cardiovascular events. So do not delay treatment. Lifestyle modification both improves the patient in many ways, but also improves the effectiveness of pharmacologic therapy. In intensive blood pressure, people are concerned about intensive blood pressure control, but it is not associated with increased hospitalization, does not increase the risk of orthostatic hypotension in general. Asymptomatic orthostatic hypotension is not associated with higher rates of events. And is not a reason to withdraw treatment. You may want to modify treatment, but don't withdraw it totally unless you have to. For older adults, intensive blood pressure lowering may, or at least partially, arrest cognitive decline, which is an interesting finding. And there have been studies showing that treating blood pressure reduces the risk of type 2 diabetes. And what's important, and we'll emphasize this again, is the use of a multi-level, multi-component implementation strategy. Team-based care. Involve everybody in the clinic: the doctor, the nurse practitioner or PA, the nurse, medical assistant, a clinical pharmacist, if you have one available. We did in the clinic that I was affiliated with at Beth Israel. The choice of therapy in hypertension depends on the amount of blood pressure reduction. That is the major determinant of cardiovascular risk reduction is the amount of blood pressure reduction and the blood pressure achieved, not the choice of drug. There are exceptions to that. The accomplished trial showed that an ACE inhibitor amlodipine combination was better than an ACE inhibitor diuretic combination. And there are patients who have comorbid conditions which may have a non-blood pressure indication for medicines like heart failure, diabetes, atrial fibrillation. Each class of antihypertensive agent will yield a good blood pressure response in somewhere between 30 and 50% of patients. There's a lot of variability in the response to a second drug. If you stop the first one and start a second one, their response will be, approximately the same. This is a study published not too long ago as on a 23-year follow-up from the ALLHAT trial. The ALLHAT trial was published just before the 2003 guidelines were published. It was 32,000 patients, and as you can see, it did not matter in terms of cardiovascular disease mortality. Did not matter whether you were taking chlorthalidone, amlodipine, or lisinopril. So what's the approach to antihypertensive drug therapy? Well, emphasize lifestyle interventions first. Then, is the systolic pressure greater than 20 millimeters of mercury above goal? That is it above 150 overnight? Is it above 150 overnight? If it is not, and if there is no albuminuria, then either an ACE or an ARB or a dihydropyridine calcium channel blocker would be the way to start. If there's proteinuria, start with an ACE or an ARB. If the blood pressure is higher than that, start with 2 drugs. Okay. Personally, I've been reluctant over the years to start 2 drugs at the same time because if the patient complains of a side effect, you don't know which half of it is causing the problem. But if you start one and then you start the second one a month later, that in the long run, that's not going to make any difference. Then if blood pressure remains uncontrolled, add a thiazide-like diuretic. Reassess the patients, your patients after 2 to 4 weeks. Don't let the patient, don't give them a 3-month follow-up. Which is it'll take you forever to get their blood pressure under control. Avoid therapeutic inertia. That means the patient comes in, their blood pressure is too high, and you don't do anything. You don't change anything. So that's try to avoid that. As I have already said, the combination therapy is better than a maximum dose of one medicine. So it's better if you have a low dose of one drug to add a low dose of a second drug rather than pushing the first drug to its maximum. The most common causes of a lack of response are medication non-adherence, the white coat effect, and improper blood pressure measurement. This just shows that indapamide and chlorthalidone are better than hydrochlorothiazide. These studies show improved cardiovascular protection, but a subsequent study did not show that. But nevertheless, you'll have better results in terms of blood pressure lowering with indapamide or chlorthalidone because they're longer acting. These are the recommendations from the American Diabetes Association for the treatment of hypertension in non-pregnant people with diabetes. Similar recommendations. If the initial blood pressure is between 130 and 150, start one agent. Again, lifestyle management is encouraged no matter what the blood pressure is. If the initial blood pressure is greater than 150 over 90, start 2 agents. And again, if they're, and then assess according to, start one agent depending on whether the patient has or has not albuminuria or coronary disease. If they do, start an ACE or an ARB as opposed to CCB or diuretic. If they do, not, it's your choice. So the Diabetes Association in the latest diabetic care standards recommends a systolic, a blood pressure goal of under 130 over 80 for everyone, whereas previously they only recommended that for the higher risk patients. But today they're recommending it for everyone. And then, again, in similar fashion, if the treatment is tolerated and the target is achieved, fine. If they don't meet their target, add another agent from a complementary drug class, or if you're giving 2 medicines, add a third one. Now, these are these are secondary drivers of hypertension. CKD, medications. The worst offender here are the NSAIDs, because people take ibuprofen and naproxen and don't tell you about it. If you twist your ankle and you need ibuprofen for a couple of days, that's not the problem. Problem is when you take it every day. Stimulants and ADHD meds can also be drivers of hypertension. Obstructive sleep apnea and primary hyperaldosteronism. So look for it in severe or resistant hypertension, hypokalemia, sleep apnea, or people who develop AFib that's otherwise unexplained. Turning to resistant hypertension. So resistant hypertension is where the blood pressure is greater than 130/85, despite three or more drugs. But before you make that diagnosis, exclude the following: secondary hypertension, hypertension elicited or exacerbated by other drugs, pseudo-resistance, essentially, lack of medication. Are you dealing with a patient with resistant hypertension or a resistant patient with hypertension? Masked hypertension is normal blood pressures in the clinic and high blood pressures at home. White coat hypertension is the opposite: high blood pressures in the clinic and normal blood pressures at home. And the management approach to resistant hypertension is similar to what we've been talking about before. That is, exclude other causes, make sure the patient is taking his medicines, ensure a low sodium diet, maximize lifestyle interventions, and optimize your 3-drug regimen. And if the blood pressure is still not at target, substitute chlorthalidone or indapamide for hydrochlorothiazide. If the blood pressure is still not at target, add spironolactone. In this situation, spironolactone can lead to some rather dramatic blood pressure lowering effects. If the blood pressure is still not at target, check the heart rate, and unless the heart rate is less than 70 beats per minute, add a beta blocker. So the beta blockers are third or fourth line blood pressure medications. If that doesn't work, add hydralazine, or substitute minoxidil. By this time, you may want to refer the patient to a hypertension specialist. So here's a patient with a problem that we face in the clinic. This is a 53-year-old. This was actually a MAVEN consult that I got. It was a 53-year-old asymptomatic Caribbean, Afro-Caribbean man. He was from Bermuda, with hypertension and type 2 diabetes, who moved to Florida. His previous history is that he had hypertension treated with valsartan, hydrochlorothiazide, and nifedipine, long-acting nifedipine. But he had not taken his medicines for the 2 months since he'd been in the United States. His A1C was 10.2, so, self-treated with diet and weight loss. His blood pressure was 226/135, but his exam was otherwise normal, and he had no symptoms, totally asymptomatic. So the question is, what would you do? Send him to the emergency room because this is a hypertensive emergency? Order an ECG and basic labs? Order an echo looking for left ventricular hypertrophy? Order a nuclear stress test? Take 2 Valium and call me in the morning? That's a variation of the old doctor joke. Take 2 aspirin and call me in the morning, or restart his meds and follow up in 2 weeks. Put your answers in the chat. Okay, we have, all right, somebody wants to send him to the ER. Somebody wants to just restart his meds. Any others? Any other takers here? Restart meds and follow up in 2 weeks, do labs and ECG. Okay. This is not a hypertensive emergency. These are hypertensive emergencies. A blood pressure of over 180/110 with one or more of the following: hypertensive encephalopathy, intracerebral hemorrhage, acute, stroke, an acute MI, acute acute congestive heart failure with pulmonary edema, unstable angina, a dissecting aneurysm, acute renal failure, or eclampsia. So in those cases, that's a real hypertensive emergency. This used to be called a hypertensive urgency, which probably is not a good label. It's really uncontrolled blood pressure, what it is. So I would not send this man to the emergency room. I would order an ECG and basic labs. I would order an echo looking for LVH. I would not order a nuclear stress test because he has no symptoms. And the value of doing a stress test in somebody who has no symptoms is quite limited. This refers to the fact that if you just wait a while, the blood pressure may fall if he just calms down about it. So the answer is really restart his meds and follow up. Okay, so my approaches to blood pressure control and to blood pressure goals are that you should not let controversies about the goals keep you from initiating treatment. In other words, if you don't really agree that the blood pressure goal should be 130 over 80, you can disagree with that, but don't let that keep you from treating patients who have blood pressures over 140 over 90. Don't let the patient tell you that, quote, I've always had high blood pressure. They'll tell you, but don't let that keep you from trying to lower their blood pressure. I use a stepwise approach. Aim for a systolic pressure of 140. If you make it without adverse side effects, aim for 130. Again, smaller doses of 2 drugs may be more effective than pushing 1 drug to its max. And don't let therapeutic inertia keep you from changing or up-titrating medications. And so we come to a final consideration, that is adherence, improving adherence. So educate and counsel patients using motivational techniques. Simplify regimens when you can. Use fixed dose combination pills where possible. Encourage self-monitoring of home blood pressure. Write 90-day prescriptions instead of 30-day prescriptions. And then use your multidisciplinary team-based care and telehealth strategies. So, for example, during the pandemic, when we didn't have, when for a year and a week I didn't go to the office at all, I would have people take their own blood pressure and have them, set up an appointment in 2 weeks and have them show me the blood pressure. And you can still do that, so the patient doesn't have to come in every 2 weeks. And I end with Roger Blumenthal's down and dirty, so to speak, blood pressure recommendations for primary prevention, right? 120 is the new 140. I love it. Lifestyle modifications first. High risk, add meds at 130 over 80. Low risk, add meds at 140 over 90. I think if you follow that, you'll go a long way toward controlling blood pressure. To prevent a heart attack, the doctor says, take 1 aspirin every day. Take it out for a run, then take it to the gym, then take it for a bike ride. Thank you very much, everybody. And I entertain questions.
Thanks, Dr. Schulman. And just a reminder, if you have any questions, you can put them in the Q&A box, the chat box, use the raise hand feature. And while we wait for those questions to come in, I will just remind you all that when you close out of this webinar, the CME survey is going to appear in a tab on your browser. If you click on that, You can complete the CME survey, and you will automatically get a CME certificate of completion for this session if you have the correct email address, licensure, most importantly, the date, August 19th, and the speaker, Dr. Charles Schulman. If something is incorrect and you don't see it, don't worry, our team will get to it, and by team, I mean me. It just will take a little bit longer than immediate. Yes, you will get the slides. Everybody gets the slides tomorrow in an email from Zoom. It'll come 24 hours from now. So if you log in the morning and you don't see it, it's just because it's not 24 hours from now. So you will get the slide deck tomorrow. Question. If patient had severe bradycardia with one particular beta blocker, metoprolol.
Metoprolol.
Oh, sure, that could be it too. Should we avoid all beta blockers?
I think you run the risk of bradycardia with any of them. I have a feeling that carvedilol is a little better that way, but you really have to try it out. The question is, why does a patient need the beta blocker? And should you be using other blood pressure medicines instead? Yeah, do we have another question? Actually, I have Germain made a comment
Yeah.
with our the man with extreme hypertension that where we considered whether he would have a hypertensive emergency, and that is, she points out rightly that it's important to find out why he stopped taking his meds. Was it financial? Was it side effects? Was it lack of access? Why is it that he now shows up 2 months after he gets here, not having taken his meds? I would agree, and those are things to be emphasized when you're looking for reasons why people are not taking their meds.
Comment. Sometimes there are patients on atenolol.
Atenolol, yes.
These medications, they kill me. Without arrhythmia or MI history, is it just an old practice or could there be another reason?
It's old practice. Yeah, it used to be back in the days when atenolol was now I forget the brand name. It was branded. The companies were all trying very hard to convince us that their medicine was better than anybody else's. Toprolol? I don't know. That's not atenolol. Not Toprol. Oh, Toprol. Oh, Toprol XL is metoprolol, not atenolol. There are many older doctors certainly who've been using atenolol for hypertension. It was thought, because there was benefit shown in the post-MI patients, it was thought that it was, quote, cardioprotective. That turns out not to be the case. It is not. I would, if a patient is taking atenolol and their blood pressure is 125 over 75, I don't know that I would change it just to change it, but I would otherwise stop it or change it.